A very good a very good evening to all of you. On behalf of Society of Young Scientists, AIMS New Delhi, it's my great privilege to warmly welcome you all to this scientific lecture on precision multi-omic diagnostics for oncology. We are truly honored by your presence this evening. First of all, I would like to extend a sincere thanks to Director Sir, Dr. M. Srinivas, for graciously permitting us to organize this event and for his constant support. It is a special occasion for us to host a speaker whose career exemplifies the seamless integration of clinical excellence, academic leadership, and translational innovation. We are deeply privileged to welcome Dr. Shashikant Kulkarni, Deputy Division Head and Professor of Molecular Pathology and Cytogenetics at MD Anderson Cancer Center, Texas, which is one of the world's leading cancer institutions. Dr. Kulkarni is internationally recognized for advancing genomic and multi-omic strategies that enable precision and individualized cancer care. With ABMGG board certification and dual credentials in clinical molecular genetics and genomics and clinical cytogenetics and genomics, he brings over 3 decades of leadership experience, spanning academic medicine, clinical diagnostics, and industry. Prior to his current role, Dr. Kulkarni served as President and Chief Scientific Officer of Neogenomics. His academic leadership includes senior roles at Baylor College of Medicine and Baylor Genetics, as well as directing molecular pathology and cytogenomic programs at Washington University School of Medicine. Trained at some of the world's most prestigious institutions, including Harvard Medical School, Imperial College of London, and All India Institute of Medical Sciences, Dr. Kulkarni is also a respected contributor to national and international standards in genomics through organizations such as ClinGen and Association for Molecular Pathology. Sir, we truly honored by your presence and grateful that you have taken time from your demanding schedule to be with us today. We eagerly look forward to learning from your insights and experience. So now I request the senior most faculty which is present in between us, Professor Subrata Sinha sir, to kindly come forward and felicitate our esteemed speaker. Uh, Thank you, sir. With great pleasure and respect, I invite Dr. Shashikant Kulkarni to deliver his lecture on precision multi-omic diagnostics for oncology. Welcome, sir.
Thank you very much. This is an immense pleasure and honor to be back here at the institution almost 3 decades since I left. I'm very happy to share with you what I've done. But Dr. Srinivas, who was a very close friend when I was at Hostel 7 here, and helped me a lot, and we were very good friends. And Dr. Mirda sitting here was another one, and we had lots of fun time together. And so he asked me specifically to come. This was not planned at all. I was here visiting my mom, and he said, you should, if you have some time, you should come and talk to us. I said, okay, I'll. So I frantically made some slides, and he asked me specifically for this one, which talks about my journey. So I don't want to go through everything, but I've been incredibly lucky to have good friends, good mentors everywhere, and incredibly lucky to be in the right place at the right time. I think starting my career here with my PhD was obviously the start of my career, and I was very fortunate to be in the cytogenetics in the molecular space from the beginning. Since after that, I went to Imperial College Hammersmith Hospital, London, where Again, I was very, very lucky to be working with world-renowned CML physicians and clinical trial experts and basic scientists, John Goldman and Nick Cross, and who have defined the field. And then I went to Harvard Medical School to do my clinical fellowship, and then got my first faculty job at WashU School of Medicine in St. Louis, where it was really a groundbreaking partnership with our hemato-oncologist and bone marrow transplant physicians to do genomics and multi-omics in acute myeloid leukemia. And then I was recruited to Baylor College of Medicine, where it was a very unique situation where the lab was spun off as a commercial lab from the Baylor College of Medicine. So I was wearing two hats, vice chair of the Department of Genetics, which was the largest genetics department in the country, but also running the commercial operation where we did a lot of cool things with whole genome, whole transcriptome, not only in rare diseases, prenatal setting, but also in oncology. And then since I was doing hybrid commercial and academic, I was asked to join a completely commercial on the precipice of making transformational paradigm shifts in how we do molecular pathology for our cancer patients. So it's a pleasure to be here again. And what I wanted to do today was to start with a story. I always like to start with a story, the reason why we work in the field. And this is very close to home. Then I want to give you a brief overview of our institute as well as my department of pathology. In MD Anderson, it's flipped. Division is department and department is division. And I serve as the deputy division head of the division of pathology. I'll just share with you very quickly what we are doing today and what we're going to do very soon. So this is the story I was going to talk about. This is Dr. Lucas Wortman. He's a hemato-oncologist, a leukemia doctor himself. And he, unfortunately, in his residency, developed pre-B-ALL. And this is the chromosomes. I actually signed off this chromosome cytogenetics report. And as you can see here, pre-B-ALL, as you know, may have several chromosomal pathognomonic markers, but unfortunately he did not have any except one small deletion of the long arm of chromosome 12 seen here. And so he underwent standard induction, consolidation, and 2 years of maintenance therapy. Because of his age, he was doing relatively fine. But at age 30, he had a big relapse, and we had chemotherapy for him, and he had consolidation with a matched sibling, his brother, allotransplantation. He developed some GVHD, and then age 33 was the worst news for him, where he got the second relapse, but also with CNS involvement. And then he got chemotherapy. At that time, we were just getting ready to do whole genome and whole transcriptome. So we sequenced his tumor normal. So at the site of trifine biopsy, where you take the bone marrow, we took a piece of skin that was our normal, and then we used the bone marrow for the somatic testing. And we had sequential samples from his initial diagnosis, first relapse, second relapse. So we did whole exome, whole genome, and RNA-seq of the blast. So this is Lucas Wortman. You can see the chemotherapy needles. And this is Dr. DiPersio. He's world-renowned stem cell transplant, bone marrow transplant, leukemia doctor at WashU, and now the co-chair of SOHO, which is organized in Houston every year. So this is his copy number changes. If you know how to read this, these are all different chromosomes, and you can see there are lots of these losses, and there are some gains in there, but there was nothing which was actionable therapeutically. So we then looked into the whole genome and whole transcriptome, not yet whole transcriptome, but whole genome, and you can see there are still some fusions there, nothing spectacular, nothing which can be treated. RB1 loss, which is important, but more in prognostic situation, but not in therapeutic sense. And then RNA-seq showed something very unusual. There's a gene called FLT3, which is known to be duplicated as an ITD or even mutations as tyrosine kinase domain mutations was seen as an overexpressed manner. It was like 200-fold overexpression. And at that time, we predicted that this could lead him to be sensitive for a FLT3 inhibitor. Actually, it was a pan-tyrosine kinase inhibitor called sunitinib. And so you could use that drug, and we got the drug for him through compassionate grounds. And then we followed all these deletions and RNA-seq at multiple time points to look at how his therapy is working. So he was back at work, and then he was on TV, and you can see this is his diagnosis, and these all green and yellow plots are his mutational profile and expressional profile. So we could get all these information to monitor his disease and also to see how he's doing. And this was quite some time ago, and now he's doing okay. He's back in the lab. He's doing researching, seeing some patients, but he has more pronounced GVHD. So he has dedicated his life to work on GVHD. So, and Lucas Wortman was not just my colleague, but very close friends. So this was something which really inspired me to continue working on multi-omics and see how we can help not just select few patients, but also all our patients. So let me give you an overview of where I work and my division. MD Anderson Cancer Center, as you may or may not know, is one of the world's #1 ranked hospital for almost 20 plus years. And it's part of the University of Texas system. It's one of the original 3 NCI designated comprehensive cancer centers. And the mission is to end cancer for all patients and families. And we see a lot of patients. I'm not going to go over the details, but any cancer which you think is rare, and a typical oncologist or pathologist would see one case a year, we have entire clinic where we see thousands of patients per year. And so this is another slide showing the statistics. It's a very rich institute, both by research funding, but also by patient revenue, but also huge patient donor base and relationship with industry, pharma. A lot of, I would say almost majority of the phase 1 clinical trials are held at MD Anderson. A lot of faculty members, a lot of employees. So very fortunate to be associated with MD Anderson now. I don't want to go with this detailed slide here, but it's continuously expanding. The footprint is one of the largest in the Houston area. The Texas Medical Center, if you may know, is one of the largest medical centers in the world. In about 2-mile radius, there are 18 hospitals. But of that 2-mile radius, 80% is occupied by MD Anderson. So a little bit about our division, pathology and lab medicine. Our vision is to contribute not only nationally in the US, but also globally. We have huge programs for global pathology. Especially right now, we have an active program with Mongolia, in Indonesia, and few other African countries. So these are the departments. Our divisions annual revenue is $1 billion, and we have 165 plus. Now it's actually 180 faculty members in my division alone. And then we have started something unique, translational molecular pathology, which is exclusively focused on taking the clinical findings and turning into research ideas, and also collaborating with pharma and diagnostic companies to bring in novel ideas. And it happens in the Emerging Diagnostics Center, which I also play a very active role in. So what do we do today? For this is the journey of a cancer patient. So pre-symptomatic, symptomatic, after diagnosis, and active therapy monitoring and remission. So as of today, we are focused on this green box. So we do diagnosis, prognosis, therapy guidance, and therapy monitoring. We are not active in this area and this area where we are focused on. When I was in my previous job in the company, we were one of the first companies to launch minimal residual disease in all cancer types. And this was very high limit of detection, low limit of detection, up to 1 part to 10 part per million cells. So it's very sensitive methods to look at the response of the therapy and also look at relapse of the disease. And in early detection, we just started a program where we're looking at healthy population as well as people with family history. So these are some of the tests. I'm not going to go through it, but we have the best-in-class solid tumor panels, RNA, DNA. We also look for HPV, cfDNA for all 6 subtypes in liquid biopsy. This is our heme onc, the new ones. We have hundreds of different offerings, but these are the 2 major ones which we just launched. And these are some of the newer assays. As I mentioned, my passion is to do comprehensive testing in whole genome and whole transcriptome. This is what we are doing as of today. As you know, we are halfway there to completely launched it. The biggest barrier I see is not in what we can do in the lab or in the clinical diagnostic space. Its biggest barrier is the U.S. healthcare system, where reimbursement is quite tough and difficult. So we have to develop a lot of guidelines, which I'm also involved in, fight with the insurance companies, create some policy statements with the insurance companies, which we also participate in through different mechanisms. So this is what our current state is. And where do we go from here, and how quickly we can get there, and why should we even look at transformational change? So I was recruited into MD Anderson to lead this genomic charter, and they had these 4 bullet points. I'm not going to belabor reading all of it, but it was most important recognition on the MD Anderson's governing body, board of directors, and leadership, and you know, all the other donors, that we are behind in offering what we can offer in the research setting to the clinical setting. So the goal was to bring in comprehensive genomic multi-omic testing to all our cancer patients coming down the road, irrespective of insurance reimbursement. So that would require a lot of money, a lot of infrastructure. And since I have experience in doing this in the industry setting, they knew that I can help them in executing their vision. So that's what I was hired here to come for. And the knowledge has changed. So this is hallmarks of cancer in 2011. You might have seen this picture. There were like very simple mechanisms which were known: angiogenesis, cell death, proliferative signaling, growth suppressors, and metastasis. So it was very simple. And now this is the latest understanding, and you can see here it has become extremely complicated with immune and tumor promoting inflammation and so many other pathways which are involved in cancer, which are absolutely necessary to understand better in order to treat our patients. Patients are living longer, they have therapy resistance. So how do we use all this knowledge we have in a cost-effective way, an efficient way to help our patients? So that's the reason why we want to do it. And others is like if you look at panel testing today, we look under the lamppost. We are not looking in a comprehensive setting. It's not useful to if the goal is to capture in a comprehensive way all the other pathways which I just showed in the previous slide. So it's very important to go through, and cast your wide net so that you can, capture all these. So I've listed here all the technologies which are used in the clinical and research settings, and then here on this axis, you see what we need to make meaningful recommendations to our oncologist uh, on treatment and prognosis. So you can see here copy number, alterations, mutations, differential expression, structural variations, fusions, tumor mutational burden, microsatellite instability, homologous recombination, deficiency, repair, HLA. So there are a lot of these different functions which we need in order to better, recommend therapy or next line of action for our oncologists. So whole genome and transcriptome sequencing covers all these different modalities, which makes perfect sense for us to continue working on this and offer this to our patients. So this is what we are looking into today. Um, not just looking into for next 5 years. We are already on our way to validate this, and my hope is that in a year we should be able to offer this to all our patients. So you can see here these different methodologies: IHC, FISH, standard methods, targeted NGS panels, and then what whole genome transcriptome can bring. It's kind of a representation, tabular representation of the previous figure, but it sort of gives you very nice coverage of everything you need to help our patients. So why do it? And again, it's sort of the targeted panels in DNA only gives you the single nucleotide variants information, but we miss all these others, which would be very, very useful. And I'm covering some of these in the next few slides. You can see, third bullet point here, therapeutic complexity requires richer biomarkers information. And whole genome transcriptome sequencing uncovers all these clinically actionable events, and it improves the diagnostic yield and economic value. And again, you can see here uniform coverage, base pair resolution of breakpoints, tumor mutational burden. I'm actually very nervous to report tumor mutational burden out of a panel because it's mostly imputation of whole genome through bioinformatic methods, and especially when you use short read technology of next generation sequencing, it sort of leads to overestimation, and it can lead to wrong therapeutic information to the physicians. And whole transcriptome, we can not only look at the fusions, but we also confirm if the DNA mutation is expressed or not. That's what matters. And then splicing events, and then signatures, which is one of our biggest reason why we are doing it at MD Anderson for antibody drug conjugates and also tumor microenvironment. So clinical utility is very high. There is 28% more information you can get, 47% more actionable targets if you do whole genome and transcriptome. And it enhances the fusion detection and variant interpretation. In metastatic colorectal cancer, the number is whopping 81% more actionable biomarkers. And about 50% are missed by standard testing. And we can also detect rare fusions like this one, FGFR1 and PLAG1 fusion, which leads to further classification of these metastatic colorectal cancers. So very valuable information to help our patients. Cancer of unknown primary, it's a big problem in the pathology space. So our whole genome and whole transcriptome, along with machine learning models, lead to 90% accuracy in validated label data sets. And we have already shown in the research setting in the Emerging Diagnostics Center that this algorithm called Kappa, cancer of unknown primary prediction algorithm based on whole transcriptomes classifiers, is very sensitive and very useful. And we can find additional therapeutic impact alterations in 60 to like 70% of the patients. This is something which is very near and dear to my heart, transcriptomic signatures, because this is changing a lot of different classifications of different important cancer types. And it helps us to further classify, subtype these cancers, which had very homogeneous diagnosis into functional subtypes. And it can give you prognostic information, and it can help guide clinical trial enrollment, and also immune checkpoint inhibitor response signatures. So this is just one example of how you can find a hot tumor versus cold tumor. And this is based on all these features listed on the left-hand side. So T cell infiltration, immune checkpoints, tumor mutational burden, cytokine profile, and some examples there, and the immune checkpoint inhibitor response. So based on these different characteristics, you can see whether a tumor is non-inflamed or inflamed, or in other words, hot or cold. And so if the tumor is hot, it is more likely to respond to immunotherapies. And if it's cold, then it's not a good candidate. The patient is not a good candidate to immunotherapy, but would respond to monotherapy. So this is just, again, a summary of how we can use the RNA signatures, and there's a lot of work. There's a hematopathology expert in the audience here. She would appreciate, how we can use this to further classify different leukemias, lymphomas. St. Jude has done a lot of work in ALL, BALL, where they have classified RNA, also in TALL, using RNA signatures. But in our institute, our team with thoracic oncologists have further classified small cell lung cancer, and I have few slides to show you how that is done today in a clinical setting as well, and sarcoma, of course. So this is the story for small cell lung cancer. Based on the expression of just 4 transcription factors, you can see that you can classify these tumors into A and B and I subtypes, and they have huge therapeutic implications. So if you have the ASCL high, this is A, and this is the classic neuroendocrine lineage, and these are the programs which are involved in it. N, where you have NEUROD1 high, this is more responsive to aurora kinase inhibitors. POU2F3 high will be low in DLL3, and there are new targeted opportunities. And if it's inflamed, that's the strongest benefit for chemo and immunotherapy. And so this is another slide representing how you could have BCL2 inhibitors based on the transcription or aurora. You can choose PARP inhibitors, or you can send, if it's an I phenotype, then it's inflamed phenotype, then it's sensitive to immune checkpoint blockade. And this is the inflamed opportunity. So these types of small cell lung cancer can be transformed into inflamed variety by chemotherapy. And this is also a strategy where chemotherapy can be used in the beginning to convert these small cell lung cancer into inflamed ones, so they can be better responsive to immunotherapy. So a lot of exciting changes. This is a most recent paper from our group at MD Anderson, published in Nature Review on Clinical Oncology last month. So this is a busy slide, but I wanted to emphasize here, I just copied the figure from our paper. So this is, ADC, which is antibody drug conjugates. As you know, based on the cell surface expression, you can have these payloads with therapy, which can then bind to the receptors and deliver the payload directly in the cancer cell. Bispecific antibody target, CAR-T therapy, and this is more looking at the low expression of tumor suppressor or high expression of oncogenes, multiple expression signatures, which I already talked about, Neoantigen identification, again, this is very important for creating personalized vaccines and personalized therapy, exon skipping, fusions, and also confirmation of DNA variants into RNA. So this is kind of the framework which we publish, like why we should do RNA-seq and how we can bring it to precision oncology. And this work was led by Funda Merrick from our institution. So I think I want to stop here and not spend too many, too much time on slides, but have more interaction, as Dr. Srinivas asked me specifically to do so. But let me humor you with few more slides. So this is what we are doing. So whole genome becomes the standard panel. We will have no specific target panels. It also improves our operational efficiency. We can have two workflows, whole genome and one for whole transcriptome. We can automate everything with robots and liquid handlers, and it will lead us to, it will give us methylation information, DNA, RNA, as I already showed, and then we can combine it with other modalities like physician notes, imaging, digital pathology. So this is an example of Google Maps. As you know, you can see your 3D pictures and street views and all of that. So it's based on graphical information system layers. And so this is a review from Eric Topol in Scripps Institute, where he wrote a review almost 10 years ago, 11 years ago, 12 years ago actually, where he gave this future vision of how you can add all these layers of different omics to better serve our patients. And this is already happening. We at MD Anderson are already integrating through a huge data warehouse called Context Engine, where all of these informations are submitted in a central data warehouse, and using machine learning and AI tools, we can integrate all these pieces of information and then have better clinical trial recruitment, better drug development, and also better diagnostics to help our patients. So some of our trainees get overwhelmed with all this information, and I am one of them. But I think the best strategy for all of you, and includes me, all of us, is to continue learning. And I can tell you, I'm not sitting down and letting the AI revolution pass be above me. So I'm like self-learning. I show up in my AI experts' offices and try to learn. And now I'm like programming myself using Claude, vibe coding, which is anybody can do it from this room. So I think it's exciting times. Rather than getting overwhelmed, we should all get involved in this and think beyond our traditional silos. So this is where we're heading. This is where we were in morphology, and now it's all ecosystem, looking at multimodal, multi-omics approach, and then using AI machine learning tools. It's not straightforward, but I think our goal is to provide a robust, dynamic clinical decision support, which helps our oncologists in a dynamic way. Gone are the days where you give a report to a clinician, which is either PDF or it's not dynamic. Right now, it's all dynamic. It changes with the new information, changes with the new imaging data, or change in the physician notes on the current condition of the patient. This is my team. I'm very, very fortunate to have 25 plus molecular pathologists in my team, and they are all multi-specialty boarded pathologists, hempath and molecular, solid tumor and molecular, breast pathologist and molecular, neuropathologist and molecular. So this is what you need to realize your vision and your dream. And these are all the technologists and supervisors and managers in the lab. We have a team of about 200 people in my group. With that, I'm stopping here and taking questions. And I think I fulfilled my promise to Dr. Srinivas that I will have enough time for questions. Thank you. Any questions? Any thoughts, comments? Sure.
Good evening, sir. My name is Aphrodite. I am a final year PhD student in the Department of Neurology. Thank you very much for your highly insightful talk, sir. My PhD study includes whole transcriptome and whole genome sequencing separately. So I was actually exploring the idea of WGTS for my postdoctoral studies, but I have a methodological question. In terms of complex phenotypes, do you think whole genome sequencing plus WTS is more powerful, or is it long read sequencing plus WTS? Like in terms of like alternative splicing and stuff like that.
Yeah, obviously, I mean, the long read sequencing and transcriptome would be the best ideal solution. But long read sequencing, I'm not talking about research here, right? In the clinical diagnostic space, long read sequencing is still not yet prime time. I mean, when I was at Baylor College of Medicine, we had one of the largest genetics labs in the country for rare diseases, neurological disorders included, and the largest pediatric genetics department in the country. So we used to see a lot of rare disease patients where we did short read technology in the clinical setting, whole transcriptome in the clinical setting. But my wife sitting here is actually a professor there at Baylor College of Medicine who does all this work. And she is leading that integration. And now she has not only short read, long read, transcriptome, but also methylation data. And in a trio quad setting, so father, mother, kid, father, mother, siblings, and kid. So the long read obviously is the way to go, but it's it's not yet mainstream. So we use it for selective cases, for fusions and for looking exactly like you said, isoforms and all that.
Thank you, sir.
So, Dr. Kulkarni, very interesting, elucidation of the work that you do. I'm very impressed by your work on the small cell lung cancer, so where you have identified the 4 different subtypes. So my question pertains to the inflamed subtype. So what is the confidence level with which we can identify this inflamed subtype, considering that you're recommending only one marker to identify it? Because there are a lot of cancers, and especially in this part of the world, where specifically if I tell you that acute myeloid leukemia, we see a lot of inflamed tumors where rest of the profile is just like a very good cytogenetic profile, but they do very bad. And we realize that they're the inflamed kind of cancers because they don't have septicemia, but they look very septic when they present. So what is the confidence level, and do you recommend testing for anything else beyond that one marker?
No, thank you. That's a very important question. So this inflamed phenotype, we have the luxury of using other, so it's not just based on 4 transcription factors, right? We have tumor mutational burden, you have microsatellite instability, you have DNA repair, and these 4 expression of subtranscription factors. Together, the confidence level is very high. Up until now, this classification was given only based on tumor mutational burden and MSI on a panel, which was not ideal. And now with whole genome, you see a lot of these inflamed phenotype, which is high mutational burden, so more than 10, 15 mutations per megabase. So we just calculate that based on that. So it's pretty sensitive.
If there's no one else, I have just. Oh, you want to say it? Acha.
Yes, now. Sasi, I think I'll be a naive person to ask you this question, but still I would love to do it as a good friend of mine. And it's lovely to listen to you after the 1990s. the 7, hostel 7, 42, 44, and whatnot. It's been wonderful to watch the way you have progressed, the way the meticulousness in your work, and the fantastic journey from AIMS to Imperial to Emily Anderson. That's wonderful. I just want to ask you a simple question. Probably I'll be naive or I'll be ignorant. Uh, for this COP algorithm, can you really pinpoint whether this genesis is genetic or epigenetic, besides your therapeutic potential?
For the cancer of unknown
Yeah,
primary?
that's right.
Yeah, so that is based on the tissue of origin markers. So there are expression-specific markers for each subtype, right? So for example, if the primary origin of the cancer is lung cancer, so there are specific markers. There's a list of about 25 plus markers which would, in confidence, tell you that the primary origin of this cancer is in lung. Similar for breast cancer. So breast cancer is actually one of the well-studied. So there are at least 3 or 4 different types of FDA-approved signatures, which are based on expression. And there are companies like MamaPrint and Encore Type DX, and there are several others which use that as a tissue of origin calculation. And with the comprehensive nature of whole transcriptome, it is pretty sensitive. So you can detect with a reliable level of confidence the origin of the tumors. Yeah. So yeah. So the first question was, how do you come up with the tissue of origin if there is admixture of other cells around, right? So for that we use help of our pathologists, and now we're using AI to circle the tumor enriched areas, and we predict the percentage of tumor in that particular circled area. We also predict the amount of nucleic acids in there. So it's become very reliable. It's not 100% reliable, but it's very reliable. So if I see more than 20% tumor, I'm very confident that the results I give, the percentage may be off, but the mutation I see or the structural variant I see is pretty reliable, up to 95% confidence. The second question you had is how reliable is the kappa algorithm when you have lymphoid tissue infiltration, you have metastasis. Because we are doing the entire transcriptome, we have specific markers to tease that out. So we'll subtract those known markers which are known for the admixture of these lymphoid cells, right? So this kappa algorithm would help us go through that. And it's never like the algorithm told us and it's a black box. We validate it, right? So we have hundreds of different cancer tissues and even liquid biopsies where we could actually further train our algorithm. And before we bring this algorithm to the clinical setting, we take it through multiple levels of validation. So it goes through humongous validation. And then we also supplement it with other things like imaging and all that, right? So we have PET scanning available where we can, using different dyes, track the metastasis and see where the main tumor is. So it's a lot of work to train that algorithm, and it's published now, is well established that it works well. But there are many others out there. When we go to the launch of the clinical test, we will compare. We do a bake-off almost every time So we'll look at not just the algorithm we have in-house, but we will look at 3 or 4 other well-published, high-impact journal algorithms, and we'll compare and see, how our results compare. And we'll choose what is the best reliable method. Can you, would you mind to get to?
Sir, I just have a question. While you converge all of these multimodalities, you take the transcriptomic data, you just then merge the imaging data, okay? So how do you resolve the conflicting signals? For example, radiomics shows a disease progression, but your molecular data does not. So how do you then make a decision? And my second question was, because you're integrating AI and ML models, so do you see them as your final decision support tools, or then you trust your molecular pathologists for the same to make the final decision?
Yeah, it is never going to be, at least as long as I'm alive, that AI is going to take over and we don't need molecular pathologists. It's always, and we, the answer to your first question is, as I said before, it's not a black box. We don't trust it, right? So this is an adjunct. Even today in our interpretation and when we write reports, we use it as an adjunct. But, trust but verify, like Gorbachev said, right? I don't know, you guys may be too young to remember Gorbachev, right? So it's like trust but verify, right? No, it was Ronald Reagan who said to Gorbachev, right, during the Berlin War, like trust but verify. So we trust it, but we verify. So we verify at multiple levels.
Okay.
We verify during the testing phase, and we verify during the validation phase, and then we verify it with every report. So this,
Okay.
and what do we do if there is a discrepancy between imaging and all of that? We're not there yet. So this multimodal AI impacting our clinical diagnostic report, we're not there yet. It's going to be another, in our institution, it's going to be another 16 to 18 months where we get there. But we already know what we're going to do there. We're going to say it's indeterminate.
Yeah.
Right? We are not going to write anything which does not come with full confidence, right?
Exactly.
And in the end, we sometimes we feel that whatever we are doing is so important that, our word is final word, but the oncologist who's seeing the patient has 1,000 other factors which he or she makes for decision making, right? And they see the patient, we do not. We just see a portion of the tissue, right? Or the blood. So I think I'm confident that we will, in 16 to 18 months time, we will have a system where we would have a fully validated way to resolve these conflicts.
Thank you.
So
Yeah, so we are, MD Anderson is a very conservative institute. We do not like to create anxiety in our healthy people. So we individual. Oh, MRD is different. Yeah. No, because we are not dealing with a healthy individual, right? There we know the cancer already exists. Yes. Right. We can train the model on that basis, but it's not trained on a basis of a completely normal individual, right? I can tell you when I was in London, BCR-ABL fusion, which causes chronic myeloid leukemia, one of my colleagues did a study where they looked at thousands of normal people, and they found BCR-ABL fusion, but none of the patients in 20-year follow-up developed CML. None of them, not a single one, right? So finding and having that cancer diagnosis is completely different thing, right? So in MRD, it's completely different. So in my previous job, we did an MRD for in a bespoke way. So what we did is we did whole genome of the tumor. We selected about 48 markers, and then we developed a very high sensitive droplet digital PCR method, and that panel was individualized bespoke for that patient. So we had very high confidence because we only are looking for that particular mutation in that particular patient, right? So, but now it has moved on because of the newer technologies to whole genome level. So you do whole genome for tumor, and then you also do a whole genome in blood, in like circulating cell-free DNA. And because of the technology, there's a technology developed by New York Genome Center called PPMC, paired plus minus. So in order to have the mutation, you have to have mutation in both the plus strand and minus strand. That increases the sensitivity, just like Sanger sequencing, right? In old days, right? It increases the sensitivity log better. So it's like 10 raised to power minus 7. So you can detect like 1 cell per million. So that way you're very confident that what you're seeing is real. So MRD is much more, I feel much more confident doing MRD than healthy population. I did my own GRAIL sequencing. I didn't see anything, but thankfully, otherwise I would be anxious. Going to annual checkup every day, right?
Dr. Shashikant, I have a question for the checkpoint blockade inhibitors therapy. We see the responses in patients, some respond very well and some are drastically. So with your experience, the biomarkers and things which can be very well characterized as to which patients is going to perform. And my second question is the hot tumor and the cold tumor. What is the status right now? You have well-defined biomarkers by which you can transform a cold tumor into a hot tumor, making it more responsive to immunocheckpoint blockade therapy. Oncolytic viruses, for example, I'm a little curious because MD Anderson has done a lot of that.
Yeah.
So if you can just update on that, what exactly?
Yeah, so the inflamed versus non-inflamed is we already reported using tumor mutational burden and MSI, right? So the candidates for immune checkpoint inhibitors are already part of our reporting for last 6-7 years. But now with the transcriptomic signatures, where you could look at CD8 positive cells, CD4 positive cells, other immune repertoire, we can do a better job. So it's only adding to it. As far as conversion of cold tumor to hot tumor, chemotherapy is actually proactively used to create, this
But
hotness.
there's a lot of adverse effects.
Oh, there's of course.
So
Yeah.
oncolytic viruses, how?
Yeah, I mean, mRNA vaccines, oncolytic viruses, they are all being tested right now. But I will say one thing, since you're a microbiologist, right?
Right.
The responders versus non-responders has microbiome also in a big way. So at MD Anderson, I think it's one of the largest studies which we have done. And now I'm thinking about adding microbiome into the omics too, but it's so difficult because, there's no reference set, and it's like, the complexity.
It's a huge task.
It's a huge task, but it has been done at MD Anderson in a research setting, right? So I think that is the missing piece of finding the true responders versus non-responders. And they do, at MD Anderson, the several groups of researchers, they do microbiome on multi-sites. So it's not just GI tract. Every what do you call it? Every place where you have that commensurate, right? So that is, I think, is the biggest missing piece.
Thank you.
Sir, you mentioned about algorithm that you are developing. So my question is like, have you found any canonical signatures across the different transcriptomics in different cancers?
Yes. And it's not just our work. It's been historically published for last more than a decade, where there are fixed signatures for each tumor types, each cell of origin, tissue of origin types. So as I mentioned before, breast cancer cells, epithelial cells, and all of those, different types have specific transcriptomic signatures. And this is in clinical practice for a long time now, where they use this, and it's a small piece of signature. So it's like 20 genes expression, right? Now we have the all 25,000 plus its isoforms and transcripts, much more powerful data. Does that answer your question?
So that algorithm, how it works, like, can you explain a little bit on that?
I did not develop that algorithm, so I'm not an expert in that. But it's taken into consideration a lot of this historical published data, and plus looking at more and more of these signatures which are well published and well established, looking at geo expression data, and also validating it. And so they use the people who developed these algorithms. They use single cell sequencing methods to further refine their algorithms and then confirm it and reconfirm it. So it's been developed for a long time in a big research group. It's not my research group. I just use their algorithm. Thank you.
Yes.
Let Dr. Sen, he's been waiting for everybody, and then you can.
Yeah. Come. Oh, me, you said.
Yeah.
Okay. So one thing is there that, the standard question which comes to every conservative mind is cost. Okay. And one is, of course, that the cost of sequencing will go down so much that it will be cheaper than an IHC. I mean, I suppose a time will come. So that's different. But as of today, would there be a plausible kind of a, let's say, a decision tree kind of a thing that where you skim off different tumors into a kind of a most, I mean, ultimately, if required, you go to the most sophisticated test. But if not, then you stop earlier and just, to start your management from paradigm from that place. I mean, how effective are these kinds? And the other thing is, along with it, is there any reasonable clinically approved system for integrating proteomics and metabolomics also into your system? I saw one slide, but really, I mean, it's not that much perhaps developed.
Okay, no, thank you so much. Both are fantastic questions. So the first question I'll try to answer from a US perspective. You're absolutely right. The cost of sequencing is going down, and we are testing a technology called Ultima Genomics, which uses different sequencing methodology than Illumina, which is the 800-pound gorilla in the field. This technology will allow us to do somatic testing, whole genome, in less than $150, $200, and then which is different than $2,000. It's like tenfold reduction already, right? So this is what we're thinking, right? And you're absolutely, and then, so there are 2 or 3 things we think about when we triage these patients. First of all, is there enough known to not you need to use comprehensive? So heme is a very good example, right? AML, CML, you don't need whole genome for that, except if the patient is relapsed or if you want to look at, downstream. For the diagnostics phase, the other big important factor is turnaround time. So there is no way that I can offer the same turnaround time for whole genome and transcriptome as I would do for a targeted panel. In our lab, we report out all the myeloid panel. We for leukemia panel, we call it end leukemia panel in 24 to 48 hours. And we would not even finish the sequencing then, for whole genomes or transcriptome. In liquid biopsy, we have, I can share in great details later, but in liquid biopsy, we have 2 approaches. One is 700 gene panel, which looks at everything, fusions, all of that. And then there is a smaller one for 25 genes. And that is very, much asked by our thoracic oncologists who need only bunch of, ALK fusion, EGFR, and a few others, right? To make treatment decision for a patient who's not doing very well. And our turnaround time is 2 days instead of 10 to 12 days. So it depends on the clinical question. So I strongly believe that for each question, we should have at least two solutions, if not one. We cannot ever say to a physician, "Oh, this is what you get," right? We have to, learn from what they need, right? So we have another problem at MD Anderson. The patient comes from all over the world to Houston, and they are asked by our patient navigators to plan for 5 days. They come on a Monday, they leave on Friday. If we do tissue sequencing, it takes forever, like 2 weeks. By the time patient leaves Houston, they don't have a treatment plan or clinical trial enrollment, which is very frustrating for the patient. They spend all this money, they all the time. For those patients, this 2-day turnaround time liquid biopsy is best because we just take out the blood and 2 days the result is out. And we are making it actually even better where we are sending phlebotomists to their home. Before they come, we have their blood and we do the sequencing. So a lot of factors, it's not just the cost, it's the turnaround time and all the other factors. And then insurance reimbursement. So we get typically in US dollars about $3,000 to $4,000 for the NGS panel testing for tumors, cancer. Now with the drop of sequencing cost, my cost of goods in the lab would be actually cheaper if I do whole genome transcriptome because I am operationally making it so efficient and it's all automated that and whole genome sequencing, not to go too technical, does not require library prep. So it's very quick and it's very simple. And so if you do all heme, all solid tumor on one pipeline, it reduces the cost further because I can reduce the number of technologists by 40 to 50% if I move to this. So the cost saving comes not just by the cost of sequencing, but also improving the operation. The second question you had, what about proteomics, right? So proteomics is very tough. I did a huge project in a clinical setting when I was at Baylor College of Medicine with Dr. Matthew Ellis, who's world-renowned breast oncologist, where we did mass spec-based proteomics, where we coated beads with tyrosine kinase genes. So there are 100 kinases which are FDA approved. So we coated the beads with drugs and we pull down the proteins and then we ran it on mass spec. And each of these assays were run in triplicates because there's highly reproducibility problem with proteomics. And so that way we could establish a clinical paradigm to bring this in the clinical setting. But now we have other methods where we could use the molecular barcode to the antibodies, pull the protein down, and then run it on a sequencer, like we use the DNA sequencing. So there's a company called Olink, there's another company called SomaLogics. We're working with them, but that is a targeted proteomics approach. Bring down the protein, which is important in this particular cancer type, look at their quantification. So we're just embarking on that, but I think the time frame to get into the clinical space is going to be no, not yet. But I'm confident that in the Olink method or aptamer-based methods, it will be much better. Very quickly on metabolomics, we have a project for early detection of lung cancer using a bunch of markers which we use through mass spec. Sam Hanash at MD Anderson and Johannes, what is his last name, Freeman. They have done a lot of work. So this is targeted to a particular patient type. I wouldn't call them patient because they don't have the cancer yet. But these are smokers, long history of smokers or long family history. And today their diagnostic algorithm involves a low-dose CT. But the compliance for low-dose CT is less than 5%. So you miss 95% of the patient, right? So for those patient population, this mass spec, which is less than $100 of a handful of markers, has very high level of prediction whether they're going to go and develop lung cancer. So there is a project going on there. We have funding to go in the low socioeconomic areas. So in Texas, we have this Mexican border. So Rio Grande Valley, where there is a lot of poor people, smokers, they don't have healthcare. So we are implementing that metabolomics project to capture those patients who are non-compliant to low-dose CT. So it's early days.
Much, Dr. Kulkarni, for a very, very lucid talk and giving ample time for interactions. I think that is so appreciable. So, in continuation to Professor Sinha's question, if not entire proteomics, which is very difficult, is it possible, especially in the case of for targeted therapy, if you can use phenotyping of single cells in addition to the sequencing of whole genome and transcriptomic of the cells, so then you would, especially those tumors of unknown origin, it will be very important to understand what phenotype and origin they are from. So do you think adding this single, you tag the cells with maybe antibodies to specific proteins which will identify the cell type and then understand what is their transcriptomic profile, will that add value?
Absolutely, absolutely. And there are some research groups already working on that at a single cell level. So they use antibody-based methods to look at the proteins, but they also use the small single cell transcriptomic profile, and then go on to the looking at the other.
Thank you. So my second question is more, I wanted your thought on it. Like being from India and cancer being a multifactorial condition, do you think that it is important to have a national level repository for all the genetic information, the transcriptomics, and the ethnic information of the groups of people who are evaluated, so that we have a good database, robust one, based on which you can have more of machine learning and AI, which will give you further.
Absolutely essential. I think when I do, and my wife is there, she also does like reference set analysis. Most of the reference that we have is North European Caucasian population. So now there are emerging, like I can see, there was a project here in India as well, right? 1,000 Genome Project, I think. Yeah. So I actually have access to some of those patients, some of their information. In cancer, I think the International Cancer Gene ICGC has some information for Indian patients. So it's emerging, but it's not there yet. But absolutely, I think there is a need for investment to build up that database, both for normal and for cancer. Absolutely.
A lot of interesting information, sir. So I'm more interested in the initial story where you shown that patient had first and second relapse, and whole exome and genome was done. But later, what was identified was FLT3 overexpression, right? So was there a complete circle that we were able to map back that FLT3 overexpression was done because of these class of genetic variants, or is it still that unanswered question in that case?
Sorry, let me reframe your question and correct me if I'm wrong. So you're asking, like, do we know why FLT3 was overexpressed?
Yes, in that patient.
Yeah, so we looked at, we tried to find the reason, we did not find it. So we did methylation, we did other methods, we just couldn't figure out. We looked at promoter regions, we looked at long range effect of any mutations or structural variants. We could not find the reason.
So taking on the same point, if we are doing multi-omics, there will be a lot of cues that will be identified. But most of our therapies are having limited targets. So in that case, how do you see that will be progress in future with a lot of data from multi-omics, but therapies are still limited?
You're right. I mean, I'm very fortunate to work in an institution where there are so many, 2,800 phase 1 clinical trials. So we have access to a lot of these new drugs which are not yet out there. And there are processes in place, study coordinators and investigators who can enroll these patients. But you're right. I mean, the drug development is further behind than what we can do today. But I'm very hopeful of the antibody drug conjugate concept, where you could, using the expression, you could create a payload with the ADC approach. So in our in our group, we have a trial or a study called Target, where we are targeting ADCs to about 400 different expression patterns. It's a huge multi-PI, multi-investigator trial where we use not only transcriptome, but we use nanostring-based expression readout of 400 of these cell surface proteins, which we can use as delivery for the drugs.
Just to end up on the same thing, so in that case, the therapy would be a kind of cocktail for different, say, drugs, or would be a single drug that can target all of them?
Yeah, that's correct. Yeah, I mean, it's so the use of expression-based signature to CAR-T is not yet prime time, but it's used in personalizing the different T cells, today. But in addition to CAR-T, at MD Anderson, we have another program called CAR-NK, where we use the same approach to NK cells too. Exciting times. Thank you very much. Appreciate your time. Good night.
Thank you so much, sir, for your time and for this insightful lecture. So, on behalf of SYS, I would like to invite our chief patron, Professor Kalpana Luthra ma'am, to present a memento of gratitude to our esteemed speaker. Please, ma'am.
So thank you so much for to respected dignitaries, our esteemed faculty members, and all our members. So thank you so much for coming and supporting us. And I extend our sincere gratitude to us, Dr. Shashikant Kulkarni, for enlightening us and gave a amazing speech. So thank you so much, sir, and we hope your support in future endeavors of SYS. So thank you so much. Thank you. Yes, sir. Thank you so much. Thank you. Thank you. So please go for the dinners. We are arranging the dinners inside the dining hall. Beside this, please.